Good morning or good afternoon, everyone. Happy Heart Month. My name is Jenny Bogard, and I am the Executive Director for the National Hypertension Control Roundtable. And we are so delighted that you have joined us today. Before we get started, a quick reminder to wear red on February 7th to honor Heart Month. So we hope to see your pictures out there on social media. We're going to be posting on it and to celebrate this month and really lift up hypertension control initiatives around this country. So I am thrilled to welcome the panelists on today's Fireside Chat on the value of team-based care for hypertension management. I would love to introduce our wonderful moderator, Dr. Chidima Ibe, who is the Assistant Professor of General Internal Medicine and Health, Behavior and Society at Johns Hopkins University School of Medicine. Chidima, the floor is yours.
Thank you so much for that warm welcome. It's so wonderful to be here with you all this morning or afternoon, depending on where you're coming from. As Jenny said, my name is Chidima Ibe, and I'm an assistant professor in the School of Medicine. And a lot of the research that I focus on emphasizes the role of community health workers in the context of team-based care for hypertension control and management, but also for other chronic conditions. And I'm really pleased to be able to help to facilitate what I know will be a wonderful panel discussion where we're going to talk about team-based care, and we'll hear from a variety of perspectives from all of the panelists. So I first would like to ask Dr. Kelsey Bryant to introduce herself, and then I'll go and ask all of you who are the panelists to introduce yourselves before we begin with an overview of what constitutes team-based care. Dr. Bryant?
Sure, happy to. Thank you all so much for having me. I really appreciate the invitation. My name is Kelsey Bryant. I'm an assistant professor of medicine at the Icahn School of Medicine at Mount Sinai, and I'm a practicing primary care physician and a certified hypertension specialist. In my role, I see patients, teach residents, and in the rest of the time when I'm not doing those things, I do some unfunded research and try to run our team-based care programs. And so in all of that, I come with the intersecting experience across different segments of this really important topic.
Wonderful. Thank you so much. Dania, can you please introduce yourself?
Absolutely. Hello, all. Thank you so much for having me. My name is Dania. I am part of the BP Reach team. It is a blood pressure reduction, equity, and access intervention among patients with cardiovascular health risk in the safety net. Our intervention works on reducing blood pressure among multi-ethnic individuals with a history of stroke or MI. Our care team includes bilingual community health workers and a study pharmacist. As a CHW, I work directly with patients for a year through scheduled monthly pharmacy and health coach sessions. We focus on preventative care by providing guidance and education with blood pressure management, medication adherence, health system navigation, and addressing many social determinants of health. So I'm excited to be here, and I hope to bring a community health worker perspective to the value of team-based care.
Thank you so much, Dania, and I'm confident that you will. And I must say, I'm particularly excited to hear from you, given some of the things that I've learned from community health workers over the years. So thank you for joining us. I'd also like to ask Dr. Garrett Au to please introduce himself.
Hello, everyone. Yeah, again, thanks again for having us. This is a great opportunity and great chat to be a part of. My name is Garrett Au. I'm a clinical pharmacist with the USC Mann School of Pharmacy and Pharmaceutical Sciences. And my background, I've spent most of my career as a community pharmacist on the dispensing side, working with underserved communities, focusing on bringing giving access to mental health medications within the community pharmacies. My current role at USC, I'm currently working more as an ambulatory care pharmacist, working alongside Dania on our project with BP Reach, helping patients control their blood pressure within the LA County DHS system. I also work with Dr. Steve Chen on the USC's Cal Right Meds Collaborative, where we're working with community pharmacies and payers and delivering comprehensive medication management services in a sustainable and value-based payment model. So thanks again for having me.
Thanks so much for being here. And last but certainly not least, Dr. Claudiana Miftari.
Yes, thank you so much. And it's a pleasure to be here. Thank you for the invite. I am Claudiana Muftari. I am a clinical pharmacist by background. Currently, I serve as the Director of Clinical Pharmacy Relations within the American Medical Association Improving Health Outcome Group. In my current role, I work with healthcare organizations and different care teams to help support our AMA MAP, which is a quality improvement program focused on hypertension control, and really supporting them in building a team-based care approach to their quality improvement efforts. Thank you.
Awesome. Thank you so much. Also, I love your blouse or dress, whatever it is that you're wearing, Dr. Miftari. So again, thank you so much to all of our esteemed panelists, and it's really exciting that we'll have an opportunity to hear from pharmacists, from a community health worker, and from a physician. But before we get started with our panel discussion, I wanted to share a few slides that kind of help provide an overarching understanding of what constitutes team-based care. And I would also just like to acknowledge that this definition and some of what we will be looking at actually comes from work that Dr. Bryant and colleagues published. So hopefully you can see my slides, and I apologize for this. So is everyone able to see the slides? Okay, wonderful. So we have, of course, our panelists, and then this definition or this idea of team-based care, that team-based care was endorsed by the American College of Cardiology and the American Heart Association in the 2017 blood pressure guideline that was published. And it's also been recommended as a best practice by the U.S. Surgeon General in their 2020 call to action to control hypertension. But of course, that begs the question, what actually is team-based care? So the definition that you see here was composed by others, but of course, written and articulated by Dr. Bryant and colleagues. And very simply, it's defined as healthcare services that are delivered by two or more providers who are working collaboratively. And as you can see from this particular slide, there's strong evidence based on the work that Bryant and others have done that indicates that team-based care is not only a model that optimizes everyone's contributions to supporting hypertension management, it's also demonstrated as being cost-effective. So in the meta-analysis that Bryant and colleagues provided or conducted, that was published in 2023, they found among 19 studies that composed nearly 6,000 participants that team-based care yielded a 12-month systolic blood pressure change of -5 for those with physician titration, compared to -10.5 with non-physician titration. They also found that the estimated costs for non-physician titration was $95 more per patient, but that it yielded a quality adjusted life years, an increase rather in quality adjusted life years. But team-based care that relied solely on physician titration cost more and yielded fewer quality adjusted life years than team-based care that was characterized by non-physician titration. So in summation, we see that it's associated with improved rates of blood pressure control, that the inclusion of non-physician members in team-based care who have the capacity to manage medications has been associated with greater blood pressure reductions. And again, as kind of demonstrated in the previous slide, in the graph that accompanied the article that Bryant and colleagues published, that it is indeed a cost-effective strategy for reducing hypertension-related morbidity and mortality here in the United States. So this allows us then to just move straight into the panel discussion and to talk through various considerations around team-based care from our panelists. So I want to first direct this question to all of the panelists when we think about the roles of different members of the team-based care team. So when you think about this, and I ask you all to consider this, what is the role of your position in this model of care delivery? And what are some things that you contribute to setting your care team for success? So that's kind of the overarching question that guides the specific questions that I want to ask all of you. So I'm going to start with you first, Dania. What's your role or what's your position in this model of care delivery? And how have you navigated your role within the larger team-based care model? And how would you define your role to other members of the team, especially when there might be overlapping expectations or even ideas around scope of practice when it comes to hypertension management?
That's a great question. As a CHW in clinical research, my role is defined as a health coach and a community health worker, but it's really defined to the patient during the first visit. I provide participants with an overview of the study. I distribute program materials, which includes a blood pressure monitor and a pill box. I demonstrate how to use the blood pressure cuff. I review educational materials. I assess digital readiness, and I walk through digital health resources. I also plan the future pharmacy and health coach calls that are sometimes in-person sessions. It's important to keep in mind that many of the patients that are joining our study are for the first time. It's their first experience in a study. Many of them are receiving health education one-on-one for the first time. And so it is very important for me to set a foundation and describe the kind of support we aim to provide. This allows for their participation to be a time of learning and improving hypertension. Many of our patients are in our study and are continuing to see their primary care doctors and specialists. However, there are some that are part of nursing programs, support groups, and are maybe seeing more than one specialist at a time. And sometimes this support can be overwhelming to patients. So at BP Reach, we do our best to work with programs by helping patients prepare for their appointments in advance. The way that looks like is that we encourage patients to bring in their blood pressure monitor and their blood pressure logs to show their providers how they are progressing or if they are having any spikes. We encourage them to bring in their medication bottles and pill boxes to show their providers how they are following instructions, as well as bringing in questions and concerns about medication side effects or continued symptoms. We remind our patients that we are here to provide guidance and extra support during our 12-month timeline. And if we are not providing direct support, we are communicating with other health providers through the portal or in person to ensure that patients are meeting their needs and having productive clinical appointments post-discharge.
Thank you so much, Dania. That's very fascinating and very important work. Dr. Au, what role can not only a clinical pharmacist, but a community pharmacist play in team-based care for hypertension management?
So, well, basically, from the clinical pharmacist standpoint, and within our study, and within a lot of these large health systems, the importance of delivering comprehensive medication management to these patients. Just number one, ensuring that patients are receiving the most effective, appropriate, safe options for medications. If collaborative practice agreements exist with physicians, being able to initiate or adjust medications based on need, based on home blood pressure readings, based on clinic readings. Or also, if there's no collaborative practice agreement in place, making recommendations or proposals to the providers and to the prescribers. We do a lot of addressing of medication adherence, like Dania said. We do anything from having these patients bring in their pill boxes, because we do provide them a pill box, filling their pill boxes for them, taking a picture of it so they are familiar with which medications are going to go in which slot. We find medication adherence is probably one of the biggest barriers that we face with patients. We're dealing with things such as pill burden, multiple daily dosing, managing their side effects. And from the community pharmacist standpoint, community pharmacists are an important part of the team as well. The important part of, they might not be within the system, but, community pharmacists are just as integral because they're accessible to these patients. There's how many pharmacies are there? I believe Dr. Chen will tell you there's more pharmacies than Starbucks in the country. So, community pharmacies are very accessible. They can do anything besides dispensing, looking at, providing education, referrals, screenings, taking part in preventative care. And all of this is a part of how we train our pharmacists within our Cal Right Meds collaborative and in training. And so these pharmacies can be that hub for these patients to go to. But and it's really important that we do a lot of these things for these patients, as Danya said, just coordinating care with the providers and being a part of the team and really helping and just making sure we're keeping the goal of the patient's health in mind, as that's the most important part.
Thank you. It's so interesting to hear your comments in light of what Dania said, because it really demonstrates kind of like the synergistic, complementary aspect of team-based care. So I really thank you for sharing those insights with us. Dr. Bryant, you have a really interesting perspective because you are not only a hypertension specialist, you are also someone who is a clinician scientist and has done a lot of research in this arena. How do you set up or direct a team? What do you do to ensure that the roles are clearly delineated so that care team members don't feel that there's overlap between who does what?
Sure, that's a good question. I do just want to first point out that both of the things that my co-panelists highlighted are so important and were happening outside of the context of a doctor's appointment. And I just want to just push this narrative that if doctor's visits alone could have solved this problem, we would have. Like, clearly we need our team members. And both Danya and Garrett just described really important components of actually driving this care home, literally. So with that, then I will answer your question. But I just want to highlight, truly the team is so important. So how do you build and direct a team? It completely depends on the resources that you have available. So thankfully, there is a good amount of literature out there, much of which is what I've drawn my work on. In the paper that you were reviewing, Chidima, we focused on studies that included medication management components and had someone titrating medications. And so if you're building that team specifically, you obviously need someone who can manage the medications, which may be the physician themselves if you don't have a collaborative practice agreement with a pharmacist or a nurse practitioner or a PA, someone else with prescribing authority. But in a world where maybe you don't have that because you're working in a more resource limited environment, there are still ways to develop team-based care programs. I sort of think of it as like a progression of how intense the intervention might be, with the most intense being something like a remote patient monitoring program with devices that connect to the EHR and a team of people responding to real-time readings, all the way down to a nurse physician dyad working in a primary care clinic with absolutely no other resources. And so the keys are really to, one, make sure that you and your team really understand the problem. Hypertension is considered to be so bread and butter by so many, but I still see it mismanaged all the time. So really making sure your team members are trained, they understand the evidence, they are following the guidelines. There's tons of clinical inertia out there. And then two, setting your patients up for success. So when you're referring patients, make sure they understand why they're being referred. My priorities in a clinic visit aren't always the same as a patient's. I care a whole lot about hypertension, and sometimes they care a lot more about their knee pain or whatever else is going on in their lives. And so making sure that I've leveled with the patient and they understand why they're being referred, so they're actually ready to engage with folks like Danya and Garrett in the community. And then three, meeting with your team regularly, making sure everyone understands the other's role. And I do think it's actually okay to allow for some overlap, because hypertension control or efforts towards hypertension control actually really require some redundancy. If it didn't, this would be so much easier. Like, the vast majority of these cases are not clinically complex. It's the systems that fail getting our patients what they need across the board. So I could go on, but we have more to talk about.
Yeah, though that's so interesting what you said about essentially that some measure of overlap is actually necessary given the circumstances that different patients are, navigating it and confronting. That was a really interesting insight. Dr. Muftari, I wanted to ask you, when you think about your role, how do you navigate building trust with a patient during a team-based approach to care? And how might that trust and who within the team is most trusted by the patient either inform or help to direct the patient's care pathway?
Yeah, thank you so much for that question. And some of the answers some of the points that I will highlight are going to overlap with what Dr. Bryan just reviewed. Because really the key to, before we ask our patient to trust our team, we need to make sure that that we trust the care team members that we're working with. So the first step really, when we talk about how do you build a successful team, ties into how do you build trust within the care team. And some of those elements include, making sure that we are familiar with each other's training expertise. What are the skills and the licensure elements that we bring to the table? Spending time with the team members. That is another way that helps us build trust within our own team. Making sure that we're endorsing that everyone has a role. And that's something that needs to be continuous. And once we build this trust, among ourselves, then the second step is really relaying that to the patient. Just like it was mentioned earlier, making sure a warm handoff to someone else, a referral that Dr. Bryan mentioned, it's important because now the patient knows that we're not referring them to someone else just because we're busy and we don't have time. We're referring them because we believe that that person is the next person who has the expertise in the area we're referring them to. Whether he's referring to a community health worker because they're experts in the community resources or they're expert on the social determinants of health that you may be facing, that is important for patient to understand. And that answers the patient's why. I believe these are some things that can really drive the patients building trust to the care team and really letting the patient know that we are all communicating with each other, that the decisions that we're making for the patients are decisions that we collectively are making. It's not just my decision as a pharmacist or someone else's decision, but we collaborate and we have continuous communication. I think this is how we build trust with our patients. And then I do want to point out to the second part of the question, who within the care team, depending on who the patient's champion is or who the patient trusts in the care team. This is something that I had experienced on my practice as a clinical pharmacist in a team-based care. We all are patient champions. We all have patients' best well-being at heart. And we also know that physicians are a trusted healthcare team member and the most trusted. However, we also know that patients, depending on their past history, depending on their trauma, depending on their health beliefs, may relate much stronger to other individuals of the care team. And that person really becomes the cornerstone on driving that patient's care forward. In my case, sometimes as a pharmacist, I was that person for the patient. They will reach out to me every time they needed something. But I have seen other cases when our social worker in the team was the cornerstone for the patient care, or the community health worker is the person that patient connects mostly with. So then it's our responsibility as the care team to recognize that and as a team, to be able to support that patient champions to drive the patient's care forward.
Thank you so much. I really love that you situated this idea of building patient trust in the context of we need to build trust among the team members first, and that is actually one of the ways to help build that sense of trust or engender that sense of trust among patients. And everything that you all have said really paints a really interesting picture around the importance of mutual respect for the contributions, the unique contributions of all of the team members. And with that in mind, for Garrett and Dania, you both work for the same project, and I think it would be so interesting if you would be willing to tell us a little bit more about your program. So what has been your experience working together on a day-to-day basis? And within your study, how do you manage all the logistics around coordinating care?
So as Danya mentioned earlier, so BP Reach, it's a randomized control trial, and we're looking at the use of the pharmacist and community health worker in managing hypertension. So our primary focus endpoint is looking at reductions in systolic blood pressure over a 12-month period and comparing that to usual care. And with that, we're using regular telehealth sessions. Danya will explain this to you a little bit more in detail. We're using regular telehealth sessions with our patients. We talk through text, through communicating through Teams or through Zoom on a daily basis, talking about the patient care, talking about what we're doing with these patients. And we have regular health sessions and just working together. And Don, you can probably go into a little bit more details about the coordinating and the start of the coordination.
Yeah, absolutely. So the study pharmacists and the CHW, right, are addressing medication adherence by helping patients learn how to activate their medications, calling pharmacies to check on refills, messaging providers about patients experiencing hypertension so they can be sooner. And so while patients know that I am not their primary care doctor, they do see me as a source of support and an extension of their care team. And that matters, right? That is great feedback for the future of CHWs in a healthcare setting. And it proves that team-based care works. I'm a CHW and I'm joining doctors and pharmacists to push for medication adherence and health education. I'm listening into those pharmacy calls. I'm advocating for calls when a patient's blood pressure changes suddenly. I'm helping with translation, scheduling calls, giving a cultural understanding of our Spanish-speaking patients to our study pharmacists. And this compassion, the dedication, the valuable information that is being provided by a CHW and a study pharmacist is really changing the way patients see healthcare, and it's changing the way that they care about themselves.
Yeah. And to add on to that, I think one of the things that I really appreciate about Danya and what she does is she gets a lot of information that the patients aren't going to tell me if I was on the call with them necessarily. She listens, she uses motivational reading and some other techniques to really dig deep down and get, information from the patients about a side effect that, a lot of these patients, they're not comfortable necessarily telling their doctors that they're experiencing certain side effects, that they're having certain issues. How many times do we ask a patient, how are you doing? They always say, I'm doing fine. I'm doing really well. But then you dig a little bit deeper and you talk to them a little bit more, and you're hearing things that that needs to be addressed, such as Danya's really good at talking to them about their diet and hearing things about what are you eating every day, and then it comes out, oh, I drink a cup of coffee before I took my blood pressure at home. How many times have we heard that? Danya is able to really relate to these patients, has been really just so much more information. And me and her are constantly in discussion in talking about the patient cases. So before we make our calls, we'll talk for a few minutes about, okay, we need to address this and we need to plan out what we need to do with these patients. So a lot of that also with the coordination is the planning. And okay, if happens, who are we going to talk to? When are we going to follow up with this patient? And with that, a lot of that goes into place with not only coordinating with each other, but we do have to coordinate with the providers as well. So we're talking to these patients a lot of times in between their PCP appointments, and we're seeing things where, hey, the last time the patient was seen in the clinic, their blood pressure was stable, but their home readings are all elevated. So we're taking that information and coordinating it with the doctors as well. And a lot of times with these other programs, we've seen changes being made right away, right when we emailed the doctors. So that's and I know that is a question I see in the chat. Coordinating with the doctors, it's difficult. Sometimes we are ignored as clinical pharmacists. Sometimes we're might not get an answer right away. But I think it's just a matter of making sure we're persistent, making sure we're also educating the patients to. Danya is really good at reminding the patients, this is what you need to bring your appointment. This is what you need to tell your doctor about. And that's one of the great things about working as a team is we're holding each other accountable, and we're able to really get our message across to these patients in a better way than just as a healthcare provider. Danya really relates to the patients. Just having that one person that can really understand the patients and talk to them. So I'm talking too much. Keep talking.
No, there's no such thing as talking too much. I mean, this is all so interesting and so helpful. And Donnie, I hope you don't mind, but I'm actually going to go back to you for a quick minute because I did want to ask you, just kind of in view of what you and Garrett talked about, what do you mind just discussing your role when it comes to SMBP, especially because you are working with patients one-on-one? And of course, as you and Garrett said, there's a lot of coordination that is happening among all of you within your team. But when you think about your work with patients, what has been effective and what are some of the barriers to implementing the interventions you deploy that you've encountered when you're working one-on-one with patients?
Yeah, that's a great question. So during the first visit, I am meeting the patient, I'm explaining the material, explaining what to expect for the next 12 months. And they're also receiving a blood pressure monitor that I teach them how to use. They do receive a guide for reference if they want to read over it later. And during the check-ins, we often review the different explanations of how to use the monitor. We are reviewing the effects of high blood pressure, and we're also creating SMART goals to help them work towards their personal health goals. So an example of a SMART goal about self-monitoring would be Dania will place her blood pressure and her reading logs next to the living room sofa. She will take her blood pressure at 8 a.m. and 5 p.m. This goal is specific, it's relevant, it's measurable, and it's time-bound. And so a lot of the challenges about self-monitoring depend on age and understanding of technology, in addition to the behavior change that happens post-stroke and post-heart attack. For the younger patients, I see that a lot of the times it's forgetfulness, right? They're working again, they don't have the time to take their blood pressure twice a day, or sometimes they feel better already. So you don't think it's as important to continue with their care. The good thing about the younger population is that they're more likely to use technology, so it's easier for them to track it. But when we look at our older patients, they do not have social support. Sometimes they do not read or write, so they're not able to update their blood pressure logs and are not tech savvy. Many of the general barriers are that they are taking their blood pressure after eating, after exercising. They're taking their blood pressure lying down instead of sitting up straight. Some of our patients are disabled or struggling with their mental health and have no motivation to self-monitor. And during our calls, we are asking for about 3 to 5 days of readings. If we notice spikes in their blood pressure, we do ask how they are using their blood pressure monitor to ensure that the spikes are not due to incorrect techniques. And so by focusing on education and prevention, patients are more likely to engage in self-monitoring because they understand the risks of hypertension.
Wow, that's incredible and so beautifully said. Thank you so much, Dania. What is so fascinating about your response to that question is it really allows us to think about kind of like the individual level barriers and facilitators of SMBP and the way that community health workers interface with those things. It also, on the other hand, made me think about some of the institutional level barriers and facilitators. So I actually wanted to ask both Claudiana and Kelsey 2 questions. So I'm going to start with you first, Claudiana, and then I'll go to you, Kelsey. I wanted to ask you, Claudiana, for just from your experience, what are some of the biggest barriers to team-based care implementation that you're hearing from the field? Because we heard from Dania and Garrett about what they're doing in the context of their program, and we heard the specific things that Dania is undertaking for SMBP. But from a big picture perspective, what are some of the things that you're seeing in terms of what this is looking like?
Yes, thank you for that question. First, I do want to point out that I'm very happy to say that that health centers and healthcare organizations have bought into the concept of team-based care. We're not seeing that cultural resistance as much today as maybe it was a few years ago. So that means that we're moving in the right direction. However, there is still obviously a lot of there's a lot of discussion around lack of clarity in everyone's role. There is barriers around communication among the different team members, and this is where technology solutions often become part of that solution to that barrier. Other barriers that we're noticing, specifically when it comes to the health system, has to do with team-based care beyond just the clinical team, recognizing that while right now the purpose of our conversation today is to focus on the team that provides direct patient care, team-based care as a whole does include the data team, the analytic team, the policy within the institution, the revenue cycle. So there are other team members that make this work move forward. So a lot of times when it comes to the health system level, it's making sure that everyone with the health system understand where everyone's role is and how they can support each other to make sure that the quality improvement program around hypertension control is executed and the clinical team has all the tools that they have. And then another significant barriers that we often hear, it's really the lack of resources. And that comes down to the conversation about financial restraints that a lot of the health teams are facing. There is a number of solutions around that, and those can vary anywhere from effort that is at the policy in terms of payment models for value-based care, all the way to recognizing that when you build a team-based care, you reduce the burnout. Reducing the burnout for physicians and other care team members means that you are providing a better quality of care and really job satisfaction and really savings that often we don't recognize, but these are savings that come from the turnovers that the care teams may be facing. And that turnover, it's another thing that we hear again and again. It's hard to train a new team member. It's hard to build that trust within the care team when you have constant turnover. So these are some of the biggest barriers that we hear. And part of our role is really being to, number one, identify the barriers. Number two, figure out what is that can we do today with the barriers that we have, because we do have a responsibility to the patients who have uncontrolled blood pressure today. But also a very important part of our work is thinking, what do we have to do moving forward so that we can make sure that every patient has the right care team around them to support them in their journey. And that is part of what we're doing that hopefully we can continue to discuss together.
Thank you. That I really, I just appreciate everything that you said. It's so insightful, and it actually dovetails with the question I wanted to pose to you, Kelsey. So Claudiana talked about these things from like a big picture perspective, and she really painted a portrait of all of these different factors that influence the value ascribed to team-based care within different health systems. What I wanted to know from your perspective and really from your personal experience is, how do you go about building support for a team-based care platform within a health system? And what kinds of internal support, whether it's institutional or other things that you have found to be essential, what is needed to make that a success? And I wanted to point out that I really appreciated what Claudiana mentioned regarding the fact that there are other facets of team-based care that we don't typically think about. We don't often think about the data and the analytical piece. We don't always think about the governing bodies within institutions that drive the policies and practices that are happening within that specific setting. So I'm just curious, like, as you're processing everything that's been said and your own, background, like, has that looked like for you?
Sure. I have lots of thoughts. I think that one of the big challenges that that Claudiana sort of alluded to is the inflexibility, if you will, with how various team members are reimbursed within health systems. So for an example, myself as a physician, my job is really, really unique. And I remember when I was in training, I was like, I don't know, maybe I'll be like a 50-50 kind of person. And the fact that my job exists without grant funding is like truly wild. It's very, very rare for people to have their time paid for that are clinical, that are not directly constantly billing and bringing in funds. So in institutions where you don't have a division where someone is going to pay for a coordinator, a pharmacist who has expertise in this area, who's not just spending their time seeing patients and billing for that, then you have to pivot and make whatever sort of team-based care practices you can in encounters. So if your job is seeing patients, then the focus of seeing those patients needs to be within the structure of this team that you've built. So for example, if we talk about nursing, for example, at least in my institution, RNs that aren't seeing patients in a capacity like nurse practitioners and billing individually for that, but are doing a million other supportive tasks related to patient care, have a little bit more flexibility in the roles and what they're doing throughout the day. They have, whatever they're paid for, whatever number of hours they work, and how we use those hours can change a little bit if the institutional priority is to improve hypertension control. The other area where you can sometimes find resources is within value-based contracts. And so your institution is actually probably on the hook to achieve whatever the threshold for reimbursement is for hypertension control. And so depending on who's in charge of those contracts, you can certainly make a case to them and say, hey, with X, Y, and Z resource, I think that, we can improve these numbers and therefore bring in more money to the institution. I deeply hate that many of these things are financially driven. That's certainly not where my heart is and why I care about these things. But in order to get the work done, you've really got to follow the money and make the program sustainable by being able to pull in income by billing insurance companies. When you don't have a grant in a study, which is awesome when you do, but those also end.
Yeah, yeah. The lack of, sustainable financing for certain positions within team-based care is a really pressing issue, and I appreciate you highlighting that. For the sake of time, I'm going to ask all of you to answer one last question, and then I'm going to turn it over to the audience questions. And in asking this question, I want to ask this specific question because I think you all you've answered or addressed it in some way, but I'd love to hear more specific thoughts about it. So when you think about the importance of having a champion for team-based care within a health system or practice, what has that looked like in the work that you've done, and how has that champion helped to mitigate some of these barriers to implementation, bearing in mind that, as you all have pointed out, the barriers are operating at multiple levels, whether it's individuals understanding who all of the members of the team are and what they do, the financing piece, which is, likely to become all the more salient in the coming months, or even just some of the policies and practices that are already underway within various settings. What does that champion look like, and how have you seen that, or how have you seen that role play out in the projects or the programs that you've worked on? So I'm going to start in the order of which I see the panelists. So Dania first, then Kelsey, Claudiana, and then we'll end with you, Garrett.
Yeah, that's a great question. I think our team has a very clear understanding of what our mission is. We go into every conversation with the patient with the mission, it being preventative care. And we use motivational interviewing to lead these conversations. And through motivational interviewing, we're setting a safe space for patients. And this is why many patients confide in me and our study pharmacists with the struggles that they face in their daily lives to express their concerns about the healthcare system. And because of this guidance provided, because of the listening, the compliance rate for coaching calls is high because patients feel listened to. Another thing that I've noticed over the short period of time that I work with patients is that we are teaching them how to receive our help. So because our mission is clear and we are using the resources that we can use, they are able to use our help and translate that into the long-term care and learning for themselves. And so I just want to emphasize that there must be room for intersectionality to happen between CHWs and healthcare providers so we can honor the care of patients and meet their needs. We're teaching patients how to receive our help in a short period of time with our study. Let's imagine what this help would look like if we took a step back and created bridges across the gaps that prevent team-based care from being implemented at a higher level.
Thank you. That's such a thoughtful response. Kelsey?
I just want to say that I hope that Dania is proving to you all the role of the community health worker is extremely important. So she's just had so much wonderful stuff to say. I think the champion role looks a little bit different for me, and so I will comment a little bit about liaising within a large health institution and trying to educate other providers and team members on hypertension care. And I think that it requires a lot of redundance over and over again. I am routinely asked to speak at different sections of my institution, and it's never really that different. And it requires constant re-education, and there is a lot of turnover, of course. And really, from a provider perspective, making sure people are making logical prescription decisions, focusing on single pill combinations where available, and really hammering down that education and what we can control. So folks like Dania and the community health team are really tapped into the individual patient experience, and that is so, so important. And then folks in roles like mine really need to make sure that we're making the most logical clinical decisions, because our team-based care is really nothing if we're not actually driving forward the treatment. And so I think those rules look a little different for everyone, and that's probably more mine.
Thanks so much, Kelsey. Claudiana, any thoughts about what it a champion looks like and
Yes,
implications
and
for team care?
my perspective is really gonna speak to what a hypertension champion look at a system level. And that is usually a clinician who is very passionate about blood pressure control, someone who is respected by their peers and by other care team members, and really who is ready and willing to do this work again and again and again, speaking to the repetition that Dr. Bryan just mentioned, working across the different disciplines, across the different sectors of the healthcare system. It is those individuals, our experience has been they're primarily a physician. We're seeing more pharmacists take this role. We're seeing more nurse leaders taking this role, and it will be great for community health workers to champion this work into their spaces as well. But that is what a champion looks like. And when we have a strong champion, our experience within our MAP program implementation has been that it's one of the best signals that the healthcare organization will succeed.
Thank you. Thank you so much. And Garrett?
And just to piggyback on what has already been said before, I think, a champion for us I think one of the most important part is someone who understands that everyone has a role, and everyone's role has the same goal in mind, is improving patients' blood pressure, getting patients' blood pressure under control. We have great mentors in our program, our PI, Dr. Amy Tofigi, along with Dr. Steve Chen, who are great at integrating us within the LA County health system and letting the system know that we're doing this research project to really show that, these other roles can really help and help improve patients' blood pressure and get things under control, and really be an advocate for us. So these other providers do know that what's going on and what we're doing, because sometimes there are providers who aren't aware of the program, and we'll have to explain it to them again. So just making sure that there's someone who's going to advocate for team-based care and be that person who's a spokesperson and really hammer out that this is what we're doing and this is what we're this is what our goal is. So it's been a great experience for both of us and for all of us, and we're glad to be a part of it.
Wonderful. I can't thank you all enough for answering the questions that I had for you. And I actually would like to ask some of the questions or read the questions aloud that some of the audience members have posed in the Q&A box. And I ask anyone else, we have 2 questions so far, but please feel free to put your question in the chat and I'll do my very best to read it so that our panelists can answer it. The first question comes from Francino Azevedo. And they say they are right that in Brazil, our universal healthcare system has made remarkable progress in managing hypertension, particularly with its unique approach of multidisciplinary teams deeply rooted in the community. These teams, comprised of professionals like nurses, doctors, pharmacists, nutritionists, and psychologists, work directly within the territories they serve. However, even with this comprehensive structure, patient engagement and adherence to treatment remain significant challenges. How can digital health tools and innovative approaches like health coaching and patient navigation be best integrated to further enhance the work of these multidisciplinary teams, address these ongoing challenges, and ultimately improve patient outcomes in such diverse real-world settings? So any thoughts about the utility of digital health tools and health coaching and patient navigation?
Yeah, I can start. I think when we talk about medication adherence, that is an issue that we continue to emphasize, and it's a well-known barrier to reaching blood pressure control, even though it's not the only one. And there are multiple layers to medication adherence, right? We talk about there is medication access, patients understanding on using the medication appropriately. There is factors that impact medication adherence have to do with really the patient's belief on the benefits of the medication versus the risk, or even what was mentioned earlier, once the patients get blood pressure control, they think that they no longer need the treatment, so they would stop. So and if we go into addressing every one of those aspects that are related to medication adherence, there is definitely opportunity for digital health or health coaching and patient navigators. Patient education is important. Shared decision making, something that starts from the beginning when a decision is being made to start patient on the treatment, that is important. However, that needs to continue throughout the continuum of care, and that can be done very well via the health coaching or patient navigators. Telehealth and digital innovation can help improve medication access, improve communication with the patients, just allowing patient another venue to connect with the care team when issues come up that can solve each medication issues that they may have. So there is absolutely a role for digital solution. There is a role for in a health coaching. There is a role for patient navigator, community health workers to improve medication adherence.
Thank you. Thank you so much for answering that question and using medication adherence as a way to illuminate how all of these things tie in together. Are there any other questions? Oh, thank you, Christina. So Christina Inteso asked or stated, team-based care for hypertension is fantastic. Oftentimes, people cannot afford BP cuffs for home monitoring, and insurance does not cover it. Any suggestions or ways you've been able to address that barrier?
I probably can take that one. So the insurance coverage is super challenging, and it depends on where you are, and there might be some coverage. So those you may or may not know, I think the question asker knows this, but others might not, that Medicare does not cover home blood pressure monitors, full stop, unless someone is on dialysis. I think that's really silly. But I don't make the rules. So Some managed Medicare plans will cover, and in New York, Medicaid will cover. However, in the state of New York, blood pressure cuffs are considered durable medical equipment, and there's a whole ordeal for prescribers to actually get durable medical equipment prescribed. We have to print off a physical prescription, write a letter of medical necessity that has to go through a vendor, it has to get prior authorization. It's like no one's going to do that. It takes forever. In my institution, we were able to streamline the process through a benefits manager for basically all of our Medicaid patients and some of our managed Medicare patients, where we have a form letter with the benefits manager. We said, like, do you really need this prescription? All the stuff is on this letter. It has my MPI, it has my signature, it has the medical necessity. And they agreed to combine it into one document. They process that for us and then send it to a vendor and ship it out to a patient. And so in the last couple of years, we've probably filled like 1,000 cuffs. I fought really hard to get them to finally start filling validated cuffs, which is like a whole other conversation. I think that we're there. I don't know if there've been fireside chats about validated cuffs, passion project of mine. I painstakingly went through the price list of every single one and like the different Medicaid thresholds for every state. And I was like, why not this one? Why not this one? But that solution took years. The other solution is sometimes like seed grant funding, institutions that want to help you out, writing a letter to Omron. I know other hypertension specialists that have gotten free devices to give away to patients just by writing letters and asking for them and saying they practice in certain populations and they want to test out devices. You have to be creative and ask.
Thank you for your advocacy. That's hard. That's hard work and non-compensated, but critical nonetheless. Well, we've come to the end of our time together, and I wanted to read a lovely comment made by one of the attendees, Esther Sarfo, who said, "I am a community health nurse / public health advocate in Ghana, and this is a great session for me to create a team towards hypertension to improve patients' health care. Thank you, panelists, once again. And I also want to echo those lovely sentiments. First, it's wonderful to see that we have people from all around the world attending this session. But I wholeheartedly agree with everything Esther said. It's really incredible to hear from all of you. It's been an honor to be a part of this panel and to hear the incredible insights and wisdom that you've imparted on all of us. So thank you so much for sharing your experiences with us. And thank you to all of those who attended this session for your participation and eagerness to hear from our panelists. And I think maybe with that, I should turn it over to you, Jenny.
Yeah, thank you, Chidima, and thank you to all of our panelists. This was fantastic. This is the first of a series that we're going to be doing and focusing on team-based care. So we are working on the next Fireside Chat, which should be available. I think we're going to host it in early March. So look out for information with that. But we thank you all. Join the roundtable. We love to have different perspectives and hear from all of you. I wish you all a wonderful week and a reminder to wear red on Friday. So thank you all. We'll see you again soon.